Welcome back to Care Decoded, the show where we simplify the complex world of documentation, coding, and clinical AI to help providers and health plans work smarter, not harder. So, today we are talking about something that's already reshaping the risk adjustment landscape, and I think it's more like an earthquake actually, which is version 28 of the CMS HCC model. So joining me today is someone I deeply respect, Biodun Kajopaiye. Sorry, PK. Better known as BK to his friends and colleagues. He's the risk adjustment and stars manager at CareFirst. So BK, do you want to quickly tell us about you a little bit?
Sure. I describe myself as a West Coast kid with a laid back mentality and East Coast work ethic. I've been in the healthcare space for over 15 years with a passion around, community empowerment, social determinants of health, and making meaningful change to provide access and high quality care to all those who, are in the United States. And so it's been great to see, my career journey giving me the opportunity to kind of dive into a little bit of different aspects of the healthcare industry. Started off as a, community health worker and currently, as you mentioned, a risk adjustment manager and stars manager at CareFirst BlueCross BlueShield. And so I got introduced to risk adjustment about 7 years ago and have fallen in love with the analytics and the information. And I think it's a powerful tool that allows us to better understand the populations that the healthcare industry is trying to serve and how to provide effective solutions in, providing sustainable and high quality care across the country.
Thank you for that, BK. All right. So we'll start by setting some context and setting the stage. So why does V28 matter? So for those who don't live in the risk adjustment world every day, what is version 28 and how does it differ from the previous version, which is version 24?
Yeah, so version 28 is just an updated risk adjustment model that CMS has applied to really emphasize specificity in documentation and coding, and really making sure that the right type of diagnosis codes are being inputted in the risk adjustment calculation that informs payment for health plans that manage members, especially Medicare Advantage members. And where it varies from, a numbers game is that, V24 had 86 HCC categories. V28 has 115 HCC categories. But those 115 categories are more specific, meaning CMS removed close to 2,000 ICD-10 diagnoses in the V24 model that are no longer applicable in the V28 model. But the V28 model has more categories focus on that specificity. So, CMS went through the diligence of removing HCCs that, had very low coefficients. They felt that weren't clinically relevant to care and kind of reshaped the coefficient calculations for certain diagnoses such as diabetes, major depressive disorder, and morbid obesity, so that it's a lot closer to the statistical models that they use for calculating how much it should cost to manage patients with those diagnoses.
Okay. So I think you kind of answered my question by just looking at it from a high level. So what is the sort of stated goal of making this change, this move toward more specificity?
Yeah, so it's about better calculation of cost. The goal is to really get closer to how much it truly costs to manage patients with certain diagnoses and combination of diagnoses, so that one, we can really focus on the effectiveness of care, and also understand the types of diagnoses that are prevalent within populations. And so I think this is a great exercise in, cleaning up from a, clinical perspective, cleaning up the problem list and getting providers to be a bit more aware of the details involved in managing patient care.
Okay, very good. And so far, I mean, we've been going through this transition for the last 2 to 3 years. This year, I think, is where it's fully V28. What has been the real world impact of this change?
Well, I think, take for example diabetes. Diabetes used to have three different levels of coefficients. You had your general diabetes, then you had your diabetes with, you had diabetes with no complications, you had your diabetes with complications, and then you had your diabetes with acute complications, and they all had different risk score coefficients. Now they're all equal to the same. They're all, 0.166. And so regardless of what you document for diabetes, you're going to get the same coefficient. So the focus is on making sure you document the diabetes and, you know, uh, being aware of the treatment plan, for that management. And so the impact there is, before providers were really trying to get, or look at the complication. And put a lot of emphasis on that. Now the complication is not going to carry as much weight because they're all the same. And so you're going to see that because diabetes is one of the most prevalent diagnoses in the U.S. And so you're going to see that change. But then you're going to see some other diagnoses where the risk score has gone up a bit more based on specificity. And so an example of that would be like cirrhosis of the liver that has gone up. And so paying attention to that documentation is really important. And you don't want to under document that because you're going to lose on the coefficient weight of that diagnosis. So providers have to pay attention as a bit more, and also make sure that they can validate in through the documentation the substantiation of that diagnosis, as that's going to be the most critical part as well. And so making sure that health plans as well are tracking prevalence of these different types of diagnoses within their population is going to help them then understand how it impacts the risk score calculation of their members. And then also risk stratifying their membership based off of the new model so that they can understand any type of chronic condition programs, any registries, any type of additional support that they need for certain cohorts of chronic conditions. They can allocate the appropriate resources to those members or those individuals so that they bend the cost curve of managing those various diagnoses.
Great. I'm not as familiar with the sort of the RxHCC. Has there been an impact on the RxHCC codes as well?
Yeah, that's a great call out. So the RX HCCs, because one of the major drivers of healthcare costs is pharmacy. And I think CMS has recognized that the RX HCCs were a very small portion of the risk score calculation, and now the RX HCCs is a higher impact, because a lot of chronic conditions are managed through medication. And so as a result of that, CMS has acknowledged, that impact by raising the overall influence of the RHCC on the overall risk score calculation.
Thank you. All right. So what have you seen? Like, how are these changes affecting providers in primary care or chronic care management, and who's winning and who's at risk for losing?
So I love that question because at the end of the day, this is about patient care. And we're seeing that, I used to be a practice administrator and there was a lot of very, cut and paste type of, documentation where they were just kind of taking the previous notes or general diagnoses and just kind of bring them over. Because, doctors don't document based on HCC, they document based on ICD-10, and that specific diagnoses. But sometimes there isn't as much attention to the specificity of the diagnoses for a member or a patient, and it impacts the payment of it generated to be actually take care of of the patient. Now there's got to be more attention, and I think where this is becoming more important is the provider and payer relationship because payers are the ones who receive the risk adjustment payments from CMS. They have to be more in tune with the changes of the model. But the providers, the physicians, drive the inputs of the model. They are the ones submitting the ICD-10. And so, if a provider is not documented with a high level of specificity, and you see a risk score drop, the payments needed to manage a population are also going to drop for the health plan. So the health plan has now elevated their, vigilance on improved documentation, improved risk capture, and that has flown into the provider. Now, from my vantage point, I can see that it's more challenging for the providers because now a lot of their clinical workflows involves the ability to document appropriately and, more importantly, recapture conditions that flow year over year. So your diabetic patient in 2024, who had diabetes, you need to make sure you capture that diabetes in 2025. If there's any progression to a diagnosis, you got to make sure you document that progression in the following year, as specific as possible. And the other thing that's also influenced it is not just the changes in the V24 and the V28, but also the emphasis on RADV. And so, health plans are under more pressure to continue to justify the payments they have for risk adjustment, from CMS. So not only do they have to, manage the changes in the model, they also have to manage the validation of the documentation to ensure that the models are being appropriately applied. And so I would say both health plans and providers are experiencing these challenges because providers don't go to medical school for coding. I would say they have a bit more of the pressure because payers are saying, hey, we need you to meet these KPIs. We're now putting these into your contracts, so that there is a measurable way to look at how the data inputs from risk adjustment that you're influencing risk adjustment are being sustained or managed over time because this is the new regulatory environment that we're in. So, it's challenging for providers because they have to spend more time on things that they might quote unquote think is administrative. But again, I think it's beneficial to the patient because it allows the patient ensures the patient's data integrity. They're not only in their documentation, but the level of the diagnosis or complication of their care required to manage them more effectively.
So yeah, there has to be, I think, a closer collaboration between the plans and the providers. So how are the plans motivating the provider or incentivizing the providers to do a better job of that?
Well, I mean, so with risk adjustment, incentives is very touch and go, right? Because you don't want to encourage, upcoding. You don't want to be leading the witness per se, and so you want to make sure that the documentation of diagnoses, one is valid, is applicable and relevant to the patient's care, and the documentation substantiate the level of care being provided. There has been incentives for, things like, addressing an HCC list. Plans are providing, their provider networks with saying, hey, these are the HCCs that we see within your patient panel or diagnosis codes that we see within your patient panel. We need you to confirm whether they're clinically relevant or they're not. If they are clinically relevant, document it as part of the care plan, put it in the medical record, substantiate it in the medical record, submit it on a claim, and then it'll flow into our encounters. If it's not relevant, give us feedback that says no longer relevant or not applicable or currently history of, and then we will collect that transmission and also apply it in our suspecting logic for future projections of risk score calculation. And so they are incentivizing the addressing of a diagnosis and not the quote unquote capture of a diagnosis. And that could be a compliance issue that can have other complications down the line.
Of course. Yep. Yep. I think we've seen some early data showing drops in members' RAF scores, risk adjustment factor scores post V28. So, what are you hearing from your colleagues and practice groups?
Yeah, I mean, I think where you're seeing the drops is because you're seeing changes in coefficients like diabetes. Another big one is a drop in coefficient for morbid obesity, which is a very common HCC that we see in multiple populations in the U.S. There have been changes in the substance abuse and major depressive disorder coefficients, and so those diagnoses no longer carry the same rate, even though the prevalence is pretty high. So you're seeing changes there. And then they made a lot of CMS made a lot of changes to the documentation of vascular conditions. A lot of those got moved out of the model. You're going to see a change, But as the Medicare Advantage population grows, because you're getting the baby boomers who are transitioning to Medicare Advantage at a very high rate, I think it's going to level out as documentation improves and as people are more aware of the specificity of diagnoses. That roll into the V28 model also becomes people become more comfortable with that model. So I think the initial drop is to be expected, but again, at developing that awareness and utilizing tools that support that awareness are going to help recalibrate the risk scores.
Sure. All right. And from the health plan perspective, so what is at stake if the provider network isn't fully transitioned or bought into or even trained on V28?
Oh, it's millions of dollars. It's millions of dollars loss. And there's going to be, and this is why you're seeing a transition to a lot of value-based contracts, because health plans can't afford, to be, caught with their pants down, and to say, they've got to be prepared. And again, you're also going to start seeing a lot of provider groups or health plans buying provider groups, so that they can have more control of the documentation quality, access to medical records, so that they are preparing themselves for the headwinds of this transition. And you're going to see CMS do a lot more audits. The currently right now, CMS has asked, health plans to submit up to 5 years of deletions in the last month. And saying that, hey, we're going to give you opportunity to delete, for these past payment years, but we might, do a RADV that covers, 4 payment years, and we're going to do it across the country. We're not going to select, one particular, group. We're going to do it across everybody. So the implications are very significant, and health plans, are now scrambling to think about how do they, build, their internal departments, especially around risk adjustment, finance, actuary, to be able to at a turnkey, meet these regulatory, demands, but also influence provider workflows, provider structures, provider contracts, so that things feed into their operation in a sustainable way and in a cost-effective way. And I think that's where technology is going to play a big part in the risk adjustment world over the next few years.
Yeah, absolutely. Yeah, I think, as a clinician, I'll say that, taking care of patients is hard enough. And doing this on top of that is a whole different layer. So like you said, the more tools we can give to the providers, the better it is. And that was going to be my next question, but I think you've kind of answered that what should providers and administrators be doing today to ensure this shift?
Yeah, I mean, we've gotta lean on technology. We've also have to make sure that we create, an environment where the contracting, incentivizes the adoption of the technology. Because, technology is only as good as the inputs, right? And so we need to, one, clean up data. I think that's gonna be critical, because if we have garbage in, garbage out, right? If we're not cleaning up our data, if we're not building good data repositories, then we're doing the technology a disservice. And so how do we, create better data efficiencies to, you know, input into the technology to produce quality information that's applicable at the clinic level and also benefits patient care? And then finding tools that are high impact but low intensity. Like you mentioned, Sunil, being a take care of patients is hard enough.
Mhm,
And so we can't add another layer of stress to
mhm.
providers. We already see that, the influx of new physicians in the healthcare industry is decreased over the last few years. People are not being attracted to the profession. So those who are having to carry on more stress, more weight. Um, and so we've got to make it easy for, physicians to make the right decisions at the right time for the right individuals. And so, we have to move away from episodic care to population health, to looking at how do we, you know, find, patterns within certain cohorts of individuals or providers panel, and bucket those, patients in a way where we can effectively create systems where they're getting good quality care systematically and not just individually. I think that's going to be a critical piece. And so, creating, a clinical environment that leverages technology based off of good data, based off of identifying, you know, high risk, medium risk, low risk patients, and then making sure the data transmission as you're providing care flows through the right mechanisms that gives health plans the information they need to meet the requirements of risk adjustment and receive accurate payments to, provide resources to take care of their members. And so that has to be a very intentional and thoughtful ecosystem that is designed with providers in mind, patients slash members in mind, but also good quality health system and health system data infrastructure in mind. And it needs to be kind of enhanced with provider and payer contracts that reinforce that sustainability, but also progress as things change within the population and within the regulatory environment.
Sure. And I will add that I think interoperability of data is a big thing here, right? The data needs to flow, as you alluded to yourself, between various entities, right? So if a patient has gone to three different specialists, three different health systems, they need to be able to see each other's data. And as you mentioned, technology, if there are tools which can actually analyze those data and give very appropriate suggestions to providers at the point of care with supporting evidence, I think that will go a long way.
Exactly, and I think optimizing the point of care where we amplify clinical focus, I think is gonna be very critical. A lot of risk adjustment traditionally has depended on medical record reviews. I think, health plans are realizing they have to shift. They have to shift where they are providing information in a timely manner to the providers so that the providers can act and intervene, as quickly as possible in the point of care and send that data back to health plans so that they can be proactive in the management and resource allocation of certain members with certain types of chronic diseases or fit under certain cohorts of things like social determinants of health, etc. And then also identify which type of interventions may work best for different members of their population. But they need to do that with active information and really move towards prospective tools that allows them to do that. Because what's great about prospective is that you also get your payments up front. And I think every health plan likes getting money in hand versus money that's going to come later on, right? It's going to help. The finance guys are going to be able to have better accruals if they move things prospectively, from a business standpoint to making sure that the proactive care is what's informing the risk adjustment program.
Yeah, yeah, and to your point, I think there needs to be, from a provider perspective, right? There needs to be a lot more signal and less noise, right? So if you are giving me a suggestion, if the plan is giving me something, it better be solid, right? Where you have evidence behind it. Otherwise, physicians lose trust, right? So they don't take those things as seriously. So I think that is something that people need to look at closely as well.
And I love that point, Sunil. I think clinical integrity is important. Clinical relevance is important. Making sure that medicine is an art, and you have to make sure you add value to that art so that providers find. I like one physician told me, BK, help me find the music amongst the noise, so I have something to dance to. And so we need to give physicians music so that they can use in their priority to take care of patients, and it has to show that they can rely on that information consistently. If it's something they have to question, or if it's something that puts them at risk of providing the wrong care, they're not going to trust it. And so, like they say, trust is a glass cup. When it's broken, it's very hard to piece back together. So don't let it. So you don't want to let it break. Don't let it fall in the first place. So I think again, to your point about data, making sure there's data integrity to support clinical integrity. It's got to be complementary on both sides.
Yeah, agreed, agreed. So let's talk about the sort of long game or the future. So, do you think V28 is a step in the right direction for value-based care, or does it risk oversimplifying things because they've cut so many codes?
I think it's a step in the right direction. I personally believe that less is more. And so, really, again, amplifying focus on the right diagnoses that are going to impact care and making sure that there's a more focus on specificity is important. Because, again, that's the level of awareness needed to manage patients effectively. We need to make sure that we can calculate the cost, so that we can figure out what is the impact of certain prevalent conditions on our populations, and what is the best interventions needed for those, and resources needed for those conditions. But then also the model acknowledges that RxHCCs or pharmacy data is important, and that it's going to play a larger role in patient management. So I think it's step in the right direction. I don't think it's the last model. I think there's going to be more models in play. I, personally think that CMS is eventually going to include social determinants of health as a risk factor, or HCC, because that plays a big part, in the cost calculation of patient care. So I think it's a step in the right direction. Like anything, change is hard, but change is necessary and change is constant. And so I see this as, just a natural process of, the evolution of healthcare, and that, we should expect something more to happen, over the next few years over time.
Yeah. So to that point, right? So, what is your advice to leaders who are trying to stay ahead of those future changes, whatever they might be, right? Whether it's V29, some major policy shift, or AI disruption that everybody talks about.
So I like to start with contracting. Does your contracts enforce the right behaviors to support the changes that are happening in risk adjustment? Are you measuring risk adjustment performance across your networks? Do you know how your networks are doing and how you are doing as a health plan, or over certain risk adjustment, key performance indicators, and how does that flow into your networks? What percentage of your risk adjustment program is prospective, and what percentage is retrospective? And if you see you have a high dependency on retrospective, what is your plan to shift from retrospective to prospective? And how does your contracting, your provider network, and your commitment to, data integrity reflect that shift from retro to prospective? And then how are you, creating, have you structured your organization where there's good information sharing between your finance, your actuaries, and your operations, your clinical and your network team, so that there's high visibility on risk adjustment across the board, and that there's a relationship between what those departments are measuring and how the overall organization is performing in risk adjustment. And then the thing is, what is the maturity of risk adjustment programs within your network? Are you providing, risk adjustment education? Are you emphasizing, documentation and coding? Are you doing, coding, CDI programs, coding improvement programs? Are you making your network aware of the regulatory changes? How are you supporting your providers with technology? How are you providing them clean, clear, useful, and clinically fortified information so that they can, respond to it in a meaningful way to take care of patients, but also make sure the information flows back to the health plan and they can use it for their different risk adjustment programs, but also other clinical programs that they run. What is your plan for making sure that you are auditing and reviewing the documentation across your network, to also understand your risk for things like RADV audits? And then I would say that, how are you developing partnerships with your clinical teams? Because it's not a us versus them. It's we need to get this right. Because when health plans and providers get this right, the patients benefit. One of the things that drew me to healthcare is that if you do the right thing, the business will come. You know, those who join, healthcare are very altruistic, and there's an emphasis on doing the right thing. And same thing happens with risk adjustment. If you do the right thing, if you focus on the foundational needs of being as accurate and as possible in your diagnoses and in your documentation, and making sure that information is captured, consistently at a high quality, and that's what you're sharing with CMS, then you're reducing your risk, and you're going to get accurate payments from taking, first from CMS for taking care of patients. Health plans need to really focus on the accuracy element of risk adjustment and not just the business element of risk adjustment. Because if you focus on the accuracy, then the business will take care of itself.
I think that's very solid advice. And as you said, that's really yes, it's more effort, but it's a very low risk approach, right? It sets people up for success at the end of the day, right? Sets organizations up for success. So that's great advice. So yeah, BK, this has been incredibly valuable, not just for decoding version 28, but also helping our listeners, lead with clarity and confidence in this moment of major change.
And I would say, Sunil, as a person who works for a health plan, it's important to elevate the clinical perspective, and make sure that is part of the tools that you're using. I've talked to and worked with tons of vendors, and there's, a lot of them really focus on, the health plan perspective, first, and then let that flow into the clinical perspective. I actually, recommend doing starting with the clinical perspective first, and then seeing how that flows into the health plan perspective, and build your tools around that, because the technology has to impact patient care and benefit patient care. And the technology has to make it easier for providers to do what they do best, and that is take care of patients. And then once that happens, then the other elements will naturally be high value and high quality, so that then the health plan can capture that information, package it in a very strong way, and then deliver it to the regulators to say, hey, this is what our acuity of our population looks like, and these are the resources that we need to take care of the population that are we're responsible for. And I think if we can do that and build tools that facilitate that perspective, I think we can get very far. But again, it requires partnership, collaboration, and an honest conversation about information that really matters.
Absolutely. And as you know, at InfoSign, that's what we're trying to do. We are trying to build these types of tools, which are provider first. I started the company as a provider, and still that is our focus. But that's what we want to do as well. Have solid clinical tools and partner with payers as well, so that it's a win-win situation for everybody, including CMS patients, plans, and providers. So
Exactly. And that's what healthcare is all about, is about creating win-win situations across multiple partners. And if we can do that, with clarity and with transparency, and good communication, I think, we will have a solid foot to stand on.
great, great. And thank you for your time, BK. Appreciate it.
Appreciate it, Sunil. This was a great conversation. Thank you for the opportunity.
Of course. So, to everybody tuning in, if this episode helped you connect the dots between coding changes and real world care, please follow the show and share it with a colleague. And let's keep decoding care together. All right. Thanks, everyone.